Hello, hello, hello. Welcome to my channel. Let me know if you guys can hear me. Just drop where you are watching from in the chat, but also let me know if you can hear me. But welcome. Today, we're going to have a really great discussion about reproductive health and also navigating wellness for Black women to prepare for them to go abroad. So first, let me know again if you can hear me, but today we're going to focus on a couple different things that you all have asked for. We're going to talk about fibroids, PCOS, preconception, pregnancy, how to be as healthy as you can be to have a healthy pregnancy and delivery, and also touch on in vitro fertilization or IVF, where one of my guests shares their journey, their own journey. So to my subscribers, welcome back. And if you're new to my channel, welcome. Let me introduce myself and then my guests. I'm Dr. Natasha Ramental, also known as the Medical Tourism RN. I'm not a physician. I am a doctoral trained registered nurse who's worked in the emergency department and the post-anesthesia care unit for a number of years. So here on my channel, I actually cover all aspects of medical tourism for Black women if they decide to seek healthcare or treatment abroad for things from cosmetic surgery to cancer, fertility treatment, anything you can think of, but in order for Black women to make the most informed decisions about their healthcare and also to have the best outcomes and experience. So if this is of interest to you, make sure you subscribe to my channel and hit the notification bell so that you're notified when I post a new video. So this topic was the most requested topic since I did a video on the best countries for IVF. That video was done a couple months back. If you haven't watched it, please, I'll put it in the chat. I'll drop the link in the description and in the chat. But it was also followed up by another video entitled Safest Countries for Black Women to Have a Baby, where I cover the countries that have the lowest infant mortality rate and also the lowest maternal mortality rate. So I'll drop a link also for that video in the chat and description. If you have any questions or comments throughout, we want you to be engaged with us, with me and my speakers. I ask you to please just go ahead and join in, share, but I'm going to jump right into our discussion because I am extremely excited to have two of our guests today. I'm going to have them introduce themselves and provide a bit of background before we get into the discussion. Dr. Nikita Dean, do you mind introducing yourself and sharing a little bit?
Hi, my name is Dr. Dean. I'm a OBGYN trained with the interest in providing care in underserved populations. I've done a lot of work internationally as well. And so I bring expertise from this country, but also some knowledge from other countries and practices as well.
Thank you. And Aisha Jenkins, please introduce yourself.
Hi, I'm Aisha. I am host of the Start to Finish Motherhood podcast. I'm a mom of 2 children conceived using donor sperm, IVF, and IUI. I am a single mother by choice, and that just means that I just used a doctor and a sperm bank to conceive my kids. Thanks for having me.
Excellent. Thank you both for being here. So one of the reasons why this topic I think was resonated with many people was because particularly those in the US, Black women in the US. The US has the highest infant mortality rate and also the highest maternal mortality rates for developed countries. The maternal mortality rate for non-Hispanic Black women was 70 deaths per 100,000. And so Black women are more likely to die of pregnancy-related complications than white women. So because of this, I think what I've seen is there's been an uptake in what's called, so there's medical tourism, but there's an aspect now called pregnancy tourism. And that's essentially people are leaving, whether they're leaving already pregnant to have their children abroad because they want to have a safer pregnancy, or they're seeking maybe to become pregnant, and because of a number of things, but inclusive of costs and other things in the US, they decide to go elsewhere to take part in this new form of tourism so that they can get pregnant abroad, even if they return back to their home country. So that is an uptick in that. And I think that has led to a number of people wanting to learn more about what is involved in this pregnancy tourism. So the first question I want to ask, and it's related to what I just said, is about socioeconomic drivers that led to the increased medical tourism, because I don't believe it lies only in socioeconomic drivers, but certainly I wanted to get your perspective as a practitioner, Dr. Dean, about what you feel are maybe contributing or attribute to the really deplorable maternal mortality rates here in a developed country like the US.
Before I can answer that question, I do want to give some additional information.
Mhm.
So, when we think about maternal mortality, that's pregnancy related. It goes beyond the pregnancy period. You also have to consider the postpartum period. And so statistics usually use up to the 1 year after delivery. And so when we think about maternal mortality, most deaths actually happen in the postpartum period, where 50 to 60%. So in this country, number one cause of maternal deaths is related to substance abuse, suicide, and mental health issues. So it's important for people, even if they're doing medical tourism, to help with conception of a pregnancy, delivery of the pregnancy. They are still a vulnerable population even after delivery up into a year. So it's important to be aware of what are the things that are caused. And I feel like in this country, now relating to the socioeconomic things that you mentioned early, as a developed country, we are the only country that does not provide any paid maternal leave. And thinking about as a mother who may have stresses with finances, maybe she had a complicated delivery, maybe she had a complicated postpartum period, but yet she has a financial burden to think of as well. That can cause mental health issues and things like that. So other developed countries provide some type of maternal leave, whether it's for, I think the other countries maybe at the least is about 10 to 12 weeks, with some countries up to like 92 weeks with paid maternal leave. So I think that is a big factor, because we know that for motherhood, successful motherhood and allows for a community, but we also are an individualistic nation. And so do we actually create those communities that is helping support our mothers? And then when we, when we are having mothers not have any financial stability after delivery, that can cause a lot of mental strain. So I think that's one of the contributing factors. Other things that are contributing, again, is accessibility. We do know in some factors that lower socioeconomic classes may have lower access. But in this country, there's a lot of compounding factors, because there are countries with less money than us that's doing better in maternal health. And so we have to think about what are those other layers, implicit bias, racism, and things like that, that's also contributing to the narrative.
Thank you for that. That's something that I didn't realize. The first part of what you mentioned with the statistics about 60% of all of that happens after they've already given birth. I didn't realize that, and that's huge, because the mental health ties into even just postpartum and everything that a woman may go through after going through a pregnancy, depending on any type of support they may or may have not had, how difficult it was, whatever it may be. But then also the leave that you mentioned. I get jealous sometimes when I hear about some of the leave that women in other countries have had, because when I got pregnant, I have 3 children, and when I got pregnant, it was 8 weeks, and if it was a C-section, it was 10. And I had people who in Chile, I visited there, and they had 18 months for one child, and they had things in place to not to secure your job. So you were also getting paid a portion of whatever your salary was, and they could not fill the position or not have a position for you when you returned. And there were some cases where I said, okay, well, what if you decide to have another child within that 18 months that you're bonding with your first child? And they said they add another 18 months to that and still protect your job. And I was like, wow, this is amazing. And in Canada, I know I have some family there, and a lot of them they have their bonding time, and they don't even think it's as much, and it's up to a year. And I'm thinking, I was like, you have no idea what
Mhm.
others in the US are faced with. So I really appreciate that, because a lot of times the conversation gets stuck, at least in the US, around it being socioeconomic drivers and them linking that to faces that look like ours. And that's not the full picture. So I appreciate that. Um, One of the other things I wanted to talk about pertaining to just childbirth and getting towards that is, so there's a number of cases that you can see. Literally, you can just look up Black maternal health, and it has become more of an issue where it's being highlighted by different organizations that are advocating for Black mothers. And one of the things that I've noticed is that even clinicians themselves are falling victim to some of the things that pertaining to maternal mortality and infant mortality. You shared with me a case that was pretty well publicized of Dr. Shanice Wallace, who was a pediatric chief resident at the Indiana University School of Medicine. And if you all don't know about it, I just encourage you to Google it. But she developed preeclampsia, a pregnancy complication involving high blood pressure, which in the US seems to be more common among Black women. One of the things I know is that, in turn, Blacks on a whole have highest rates of high blood pressure in the US. So 2 in 5 Black women, or 43%, suffer from hypertension compared to 27% of white women. So one of the things I wanted to ask you before, I know that's a little bit later on in pregnancy, but I wanted to ask you about what types of things, because these are things that are preventable. So I'm just curious about what you can share that could help maybe Black women on a whole with during their pregnancy, for hopefully not having to endure preeclampsia or eclampsia during their pregnancy period.
So when it comes to, we're still trying to understand preeclampsia. We know it has something to do with the placenta, but we don't quite understand the pathophysiology 100%. However, it's important to have protocols in place to recognize the symptoms and know when to do things and who are at an increased risk of developing preeclampsia. So I can't speak at all places, since primarily most of my training and practice have been in the United States. But in the United States, there are different bundles to kind of help improve and create protocols for recognitions of obstetric emergencies and obstetric urgent situations. So when it comes to preeclampsia, when we think about it from a preventative standpoint, who are at an increased risk of developing preeclampsia? So people with diabetes have an increased risk of developing preeclampsia. People who have developed preeclampsia in the previous pregnancy, people who have a history of hypertension prior to the pregnancy are at increased risk of developing preeclampsia. And so maybe about 18 years ago, we had noted that taking a baby aspirin during the pregnancy with patients with the risk factors does decrease their chance of developing preeclampsia later on in the pregnancy. So one is, do you have one of those risk factors that would be recommended for you to take a baby aspirin to decrease your chance of preeclampsia in the pregnancy? Another thing is if you have like hypertension or diabetes, is that well controlled? Maybe before getting pregnant, if those medical issues are not well controlled, maybe we need to get that better control to kind of help decrease the risk of developing preeclampsia later on. But then once someone is pregnant, we identify possible risk factors. We put them on the baby aspirin to help decrease that risk. Are we doing appropriate monitoring during the pregnancy for concern of preeclampsia? So the diagnosis of preeclampsia is any woman with who has 2 elevated blood pressures or more throughout the pregnancy starting at 20 weeks. And the reason we say above 20 weeks, because then this shows hypertension that's related to the pregnancy. For some women, they may not have gotten care prior to the pregnancy. And so I would have diagnosed them with hypertension last year, but I never saw them. So if they have hypertension in the beginning of the pregnancy, this is usually chronic hypertension, not necessarily preeclampsia. And so so that's why when you're going to your prenatal visits, we're checking your blood pressures every visit, because we know that if your blood pressure is starting to elevate, you don't have a history of hypertension prior, but now your blood pressure is increasing. Am I concerned for preeclampsia? And some preeclampsias are, I'll use the layman terms of just like mild preeclampsia, which means that we can allow the pregnancy to continue just with closer monitoring. But then some preeclampsia is severe, and that we may need to start thinking about delivery, because the blood pressures are so elevated that you are increased risk for like seizures and strokes and things like that. So the important thing is identifying, if you have it, is to talk with your practitioner so they can identify, do you have risk factors for preeclampsia, so that we can start you on appropriate medication for it and to prevent it. Then are we actually monitoring your blood pressures appropriately throughout the pregnancy and your symptoms of preeclampsia during the pregnancy? And then once you are diagnosed with preeclampsia, what is the appropriate delivery plan for you and the type of preeclampsia that you have? And then also making sure that we decrease the risk of those complications that can happen with people who have preeclampsia, like cardiomyopathy, which is weakening of the heart, seizures, strokes, and things like that.
So that's interesting, because I only knew about preeclampsia and eclampsia being part of the whole hypertension issue. And you had mentioned diabetes briefly, saying that some of that plays a role. I'm curious.
Well,
yeah.
So when you think about preeclampsia, while we don't understand how it works 100%, we do understand that it's about the vasculature. So your vessel, so any medical condition that causes thickening or of the vessels, and that causes increased resistance, which increased resistance leads to high blood pressures. Well, diabetes causes changes in your blood vessels that increases your risk of developing preeclampsia. So anything that can increase changes to those vessels does it. While a lot of people may or may not know, things like lupus, again, chronic hypertension before being pregnant, kidney disease, because all of those things have changes in the vessels that leads to that pathophysiology that leads to preeclampsia.
Okay. No, this is good, because another thing is Blacks also have a disproportionate burden of diabetes. Black adults in the US are 60% more likely than white adults to be diagnosed with diabetes. And a study revealed that non-Hispanic Blacks were found to be twice as likely than non-Hispanic whites to die from diabetes. So I know that there could be a chronic issue, or with women, Black women, there can be gestational, well, not just Black women, but gestational diabetes as well. So that's something to think about. And I didn't realize that it even played a role in this. So that's really an educational thing for me as well. One thing I want to do right now is say thank you guys for tuning in. Dee, I see you. Thank you. Christine C, thank you for supporting. I know you said you retired and no children, but you're here to support and learn. So there's always something to learn. We're talking about women's health in general. We just might focus a little bit more on reproductive health, and that's still not exclusive to you. Okay. One of the things that I've gotten a lot of questions about, and I'm hoping you can also share a little bit more on this, is on fibroids. And Black women have a higher rate of having instances of fibroids. And I'm just curious about, well, let's talk about, well, what is a fibroid? And then maybe we can go into other things like how does it affect pregnancy?
So how I kind of explain it to my patients is, have you ever seen a mole where the skin is like thickened and it's like out protruding the rest of the skin? That's how I kind of think about fibroids. Fibroids is in most cases benign tissue, and it's extra tissue that grows in different layers of the uterus. Why it grows, we don't understand it on a microscopic level, but we know it has to have some relationship with the female hormones estrogen and progesterone, because we know when we use treatment that minimize that, some of those fibroids stop growing, or the symptoms that people are experiencing from fibroids are reduced. And so there's also maybe some inflammation or inflammatory component to fibroids, and then there's also some thoughts of a genetic component.
Mm.
So while fibroids are very common in African Americans, it's common in all populations. So most people may not realize they have fibroids, because they just like, oh, my periods have always been heavy, never had any imaging or anything, and that's why they don't know. But when we look at women who are in like their 20s, about 20% of people will have fibroids, just general. And then when women are about in their 50s, about 70 to 80% of women are going to have fibroids, but 70 to 80% of people don't know they actually have it. So when we think about the 50s, about the 70% will be about the whites, and then 80% for people of African ancestry. So we do think there's a genetic component, but again, one of the things I feel like why we don't know as much as we probably could is, and this is like a little another topic, is women's health topics don't get prioritized when it comes to research. So that's probably why we don't know as much as we probably could. But again, there is some racial or maybe some genetic components of it that explains some of that difference. But fibroids are very common, so there's also maybe some hormonal things that's contributing to the situation as well.
Do you think there's anything environmental also? I'm just curious.
Yeah, because the environmentals can interfere with your hormones, and
Okay.
with we know that in this country, there's steroids and all this stuff in our foods, and so that can contribute to that inflammation slash hormonal changes that is known about fibroids.
Yeah, because even like the standard American diet, there's a reason that whole acronym SAD, it's such a poor diet. It is sad, right? So a lot of people who have either moved abroad or just kind of bopped around outside of the US have stated that a lot of times, whatever they may be experiencing in the US, and particularly I've had some people talk to me about fibroids, when they've gone to another country for 6 months to a year, they have not had that issue. Either they've shrunk, they've gone away, whatever it is. And it's the change of environment, change of the food, where they don't have as many hormones and whatever it is they're eating. They don't have pesticides and all those things. So that's one of the reasons why I asked that, because it has been a big thing that people have said they've noticed a main difference and have unintentionally lost weight as well. Maybe they walk more and didn't realize it because maybe in the US they might be using their car. But the other piece of that is the diet and overall wellness, because sometimes it's a lot slower in terms of work-life balance in these countries. So they spend a lot more time getting to know their neighbors, their families, their friends, and spending more time doing those things. Wellness, just overall wellness. Yeah, so that's why I asked for that. And actually, Dee just mentioned in the chat, there's a reason that's justified, and there is a justified fear of participating in research. That's true. There's not a lot of research done specifically, even for women, not much less Black women, but like with women as a whole. So to make definitive statements about certain things. So yeah, you're right. I agree with you on that. So one of the things I wanted to ask, because fibroids is such a popular topic, is can this, or how does fibroids, can it affect fertility? Can it cause infertility even?
So it can cause fertility, and then it also can cause complications during the pregnancy. So I am very visual. I'm sorry I don't have a diagram to explain this, but there's 3 different layers of the uterus, and the endometrial layer, or the submucosal layer, where a pregnancy would, develop. When people have fibroids in that location of the uterus, it can cause issues with miscarriage, because how I like to think of it is, the uterus is a home to house a pregnancy, But if that home has irregularities and imperfections, like the window is broken, the door is wide open, like it doesn't have security to allow that pregnancy to develop, and then it can lead to a miscarriage, or it can not allow implantation to happen at all, and so you keep leading to fertilization that doesn't lead to a pregnancy. So fibroids can lead to aspects of infertility, especially when it's located in a certain part of the uterus.
Okay. All right. And so I know you mentioned earlier, maybe someone didn't know they had fibroids. So how would someone actually know? Is there a specific imaging test? How would they know for sure that they have fibroids?
So the thing that I say is, be suspicious if you have heavy menstrual cycles. While there are other different causes, a lot of people will have fibroids as a cause of their heavy menstrual cycle.
Mhm.
So, for instance, people will just say, like, oh, I'm changing a pad every single hour, and they just accept that that is normal.
Right.
It may be normal for them, but that's not normal, because that's an excessive amount of bleeding. And so that would be someone, if they told me about their menstrual history, and I'm hearing about how long their menstrual cycles last, where a typical lasts like 5 days, but they're telling me theirs lasts like 14 days. Or there's someone where, the typical person should have one menstrual bleed a month, but they're having two, or they're bleeding in between menstrual cycles. That would be a red flag. That'd be like, I'm wondering, what do they have, fibroids or some other gynecological issue that is contributing that? Because heavy menstrual cycles that is causing people to be anemic, that's causing people to need blood transfusion, that is not typical. And so that should be further investigated.
Okay.
And then another thing is people having severe abdominal pain with their menstrual cycles. While it can be other conditions like endometriosis, but some people, that severe pain is the bulkiness of those fibroids and how large those fibroids are, that when the uterus is contracting to expel the blood out, it's contracted on those benign tumors or those fibroids, and so therefore cause a lot of discomfort during the menstrual cycle.
Okay. And typically for treatment, is it usually surgical, or is that usually the route when depending on how large they are or how they are concentrated throughout? Because I only know people with surgery. I haven't heard anything else, and I'm sure there's other ways of handling it.
Yeah, so it depends on what are their symptoms, what are their goals, and then how severe are those symptoms. And so there is expected management, because again, remember, I mentioned a lot of people have fibroids, they don't even know they have it. So for them, we don't need to do anything, because it's not doing anything for you. Like, it's present, it may only be like 2 centimeters, but it's not causing you pain, it's not causing heavy bleeding, so we don't need to do anything about it. But then for some people, it's causing heavy bleeding, and so there's medical management, using some type of contraceptive. Even though we call it contraceptive to prevent pregnancy, a lot of contraceptions also help with gynecological issues. So it can reduce the blood, the amount of bleeding you have. It can reduce the amount of pain that you're having. Like me personally, I manage my fibroids with birth control pills, because that's been fine right now. But again, sometimes medical management may work, but then for other patients, it still isn't doing the job. And so then you look at surgical management, and depending on the placement of it, one is remove the fibroid vaginally through a procedure called a hysteroscopic myomectomy. So removing the fibroid through the vagina using the scope. Or if they desire to have fertility, I may have to remove, and they have big fibroids, I may have to do an incision on the belly to remove those fibroids, because they don't want their uterus removed, because they want a fertility sparing method, and they desire conception in the future. So then that's an option. And then there's also some minimally invasive methods for removing the fibroids. Those I'm less familiar, because I'm not minimally invasive in a minimally invasive surgeon in gynecology. Those takes a different fellowship that have came out to kind of help with that. And then for people with either severe cases, or maybe they just like, my symptoms not that bad, but I'm just tired of this uterus. With appropriate counseling, if they say they want a hysterectomy and their uterus removed, then they should have the autonomy to get that done. So it all kind of depends on the severity of the symptoms, and also what is the goal of the patient, to help determine which one of those management options is best.
Yeah, I think that's key, making sure that we know what the patient wants, because a lot of times people aren't listening. They just say, oh, take a look at this. We think you need to do that. And without thinking about what the patient actually desires. I'm not going to spend too much more time on fibroids, but I did have to ask this question because I've had cysts where I didn't know they were there, ovarian cysts. And I'm just curious about the difference between cysts and fibroids.
In most cases, they grow in different parts of the body. So the fibroids usually are inside of the uterus.
Okay.
Cysts are usually in the ovaries.
Okay.
But there is a fibroid that can grow in the ovary. But most of the time, if I had to like put in a generic bucket, cysts will grow in the ovaries. Fibroids grow in the uterus.
Okay. Wow, that's a good way to remember that. Yeah. I was actually going to ask you if you experienced any of that, or if you wanted to comment, Aisha. I wanted to bring you in. Please.
No, I'm just learning, because I'll get to that. But Dr. Dean, could you also, what's the difference between a polyp and a cyst and a fibroid?
So polyps is also benign tissue, but the type of tissue is softer. And so the polyp can also grow inside of the uterus. It can also grow on the cervix, which is the bottom part of the uterus. And those tends to be very vascular. And so sometimes people may complain of like postcoital bleeding, which is bleeding after sex. But they tend to be softer type of tissue and overgrowth. And again, they can also be related to like infertility, but it's really the difference in the type of tissue when we send it to the pathologist and they give us a read. And polyps tend to be smaller, while fibroids can be small, but they also tend to grow really big. And then with polyps, you usually, and again, that's usually like a uterine issue, while again, the cyst is an ovarian situation.
See, it's so amazing, because I've gone through like all these different treatments and have heard just different aspects of the whys and the hows. But this is the first time that I'm actually connecting in my head from like a pathological perspective, what all of the impacts are, because I did have insulin resistance with one of my pregnancies. I did have a fibroid removed using the hysteroscopic myomectomy procedure. So it was a 3 millimeter fibroid that had to get removed. But I think it's the difference in style of the practitioner, right? So you see me as a Black woman, you understand that there are certain things that are prevalent in Black women, and then also taking us through kind of like the foundational education that's needed. And so kind of my experience for everybody that's listening is that I went through, because I was using a sperm donor, all of my attempts at conception were medical intervention. So I did intrauterine insemination with my first pregnancy. It was a textbook pregnancy. And then with my second pregnancy, I was older. I wanted to be more efficient and going through the process. So I did 2 IUIs, and then they moved me immediately on to IVF. And when you go through, so there are 2 aspects. One is the gynecological aspect. So when I first started, I talked to my gynecologist and I said, I'm thinking about getting pregnant. Can you run some initial fertility tests? So she was great. She ran those tests. White woman, ran those tests. And then the next level up is a reproductive endocrinologist. And so when people talk about getting IVF or IUI, they're typically going with the reproductive endocrinologist. And so when you start, in a lot of cases, at least for the diagnostics and the trying to create embryos, you do get what you pay for, right? It's very expensive, but you're also paying for the expertise and the knowledge to pick and choose where the patient doesn't have the knowledge to do that. And so that is one of the most thorough workups that I had ever gotten in my life. So I got my money's worth. Now, there are two parts. There's the diagnostic part, and then there's the actual creating the embryos part and the medication. And so with my insurance, the diagnostics was covered. So let's find out what's wrong with your body. Let's find out what's keeping you from getting pregnant. And then that's where my medical coverage stopped. If I wanted to go further, because having children is not seen as a necessity, right? So you could live your entire life and be healthy and never have kids. I'm on a call and never have kids, right? And so then to go further, some insurance will cover additional interventions. Some will not. Some will cover it if you're a single person. Some will cover it if you're single or partnered or married. And so when I went through my IVF journey, it was a very thorough process.
Don't worry, it's okay. You're a mom.
Go ask Noelle. Go ask your sister. Thank you. Close my door. And so when I went through the IVF process, my second time around, I encountered, insulin resistance. So one of the workups that they do is they're checking all your hormone levels. They're checking your pituitary gland. They're checking everything. And one of the tests that they ran was the A1C test. Mm-hmm. And when they ran that test, I was pre-diabetic. I was 6.4, and I think diabetes is 6.5, but it was silent. I have a family history of it, but I had always been active, but then it was silent. So I could have easily slipped into diabetes and would not have known. And then I would have been now listed as a diabetic. And so what Dr. Dean said is absolutely true. They were like, we need to get your insulin resistance under control before we could proceed with IVF, because it does impact your ability to get and stay pregnant. And so I ended up on a medication that got my A1C in range, and then I was able to proceed with the IVF process. Now, for my fibroid, okay, then I'll give it to you when I get off. Okay. So with my fibroid, again, what Dr. Dean said was correct. I had an intermuscular fibroid, and so what that means is that it's pushing up into my uterus. And so whenever an embryo is trying to implant, you want the surface to be as smooth as possible without any bumps or ridges, right? And so if that embryo is going to implant, it's going to sit there, and then it's going to get those cells that dig into the uterine lining, I believe. And then that's what gets it to stick. And so, but if you've got a bumpy surface, it will land and it'll pop off, right? So think of it as landing and popping off, sliding off. So then you won't get to the implantation point, even though you had normal embryos, and even though the sperm was good and the egg was good, you still won't achieve a pregnancy. And so one of the first things that they'll do, based on the location of the fibroid in the uterus, they will recommend getting it removed, right? Because you're spending a lot of money, and they want to make sure that you have the best chance of getting pregnant. So I ended up having my fibroid removed. It was an outpatient procedure because they went in through the vagina, they just plopped it out. And so then from that point forward, that was during my IUI process. And IUI is the lower intervention process where they just throw sperm up into the uterus at a specific time of the month. You cross your fingers and hope you get pregnant. And so I did two IUIs and got pregnant with my second daughter, but they had to remove the fibroid first. And then, so I think those were the things that I wanted to intervene when.
No, that's good. And I'm glad you did, because you mentioned something really key, because in the process, I think it's important for people to know a couple of things. And one of them that you mentioned that was like a red flag was your insurance only covered for the health aspect. Considering trying to get pregnant and covering any other methods. So I think it's important to touch on that. After you removed the fibroid, did your insurance help you cover any aspect of your fertility process, or was that all out of pocket?
They did not. That was all out of pocket. And so I will say that there is different pricing.
Right.
So So there's different pricing for if you're paying out of pocket. And so one of the things that I would say is if you know, so do your research on your insurance coverage and see what's covered. And if you know that it's not covered, most fertility clinics will run your insurance. The first thing they do, they want their money. So they'll say that it's not covered. And so then you can ask them, well, do you have a discount for someone paying out of pocket? Do you have an income-based discount? And then if they know that their patients are paying out of pocket, they will like you can ask for coupons for any of the medication. I mean, it cuts a few percentage points off, but it's really expensive. And so we look at the people who have insurance coverage and it's just like, you're just a lucky duck, right?
Yeah.
And so, but yeah, that wasn't covered. But because I knew what was and was not covered, I was real strategic about what I did with my taxes that year. And I kept all receipts because if you talk to your tax professional, there are ways you can do tax, deferring pre-tax money for medical procedures and keep all of your receipts. And so I kept all of that and then I submitted it in. So I did get, tiny percentages back, but something was better than nothing.
Nothing, right. And that's actually interesting. I didn't realize that some of the tax implications would lead to you getting anything back if you were going that route, but that's really good. So in the chat, I put, I had a video, best countries for IVF treatment. Something that Aisha shared in just kind of sharing her journey was that the insurance piece, which you want to know what your insurance covers from what it doesn't cover. But the other piece was knowing stipulations depending on where you go for your IVF treatment. If you decide to go abroad outside the US for it, this video that I have here kind of covers the top 14 countries. But what you need to know are there are regulations about if you happen to be from the LGBTQ plus community, that you may or may not be able to do it in that country. If you're married versus single, just because of the culture. There are so many different cultural norms that are embedded in the policies of these countries. So you may think, oh, great, it might be a cheaper option and they're well known for IVF in terms of safety and other pieces or other aspects. But you might not know some of the more granular pieces that would affect you if you fall into that category, a single parent by choice, like what Aisha and her organization represents, or again, being from another population, LGBTQ plus community. And in one country, I can't remember which one off the top of my head, they allowed for eggs to be donated to the mother, but if you, not for payment. So then you had to have someone that maybe was a relative. So there's a number of different stipulations. So definitely do your research before you make a decision to do that abroad, especially on the country you plan on doing it in. If you have heard good feedback, just look into all the particulars so you go as best prepared for whatever you're going to be faced with. It's a journey in itself to go through that process with your body, but make sure at least you're meeting the minimum standards required for that country so you don't come into contact with any issues. So I wanted to say that.
And one thing I just wanted to add is, again, in this country, 50% of pregnancies are unplanned, which means that a lot of people have pregnancies without like a preconception meeting to kind of go over their medical issues, to kind of optimize that pregnancy before it even starts. But people who are considering medical tourism or people who considering, fertility treatment, they are a different type of person because you're trying to plan something that is costing a lot of money out of your pocket. So it's important to have a practitioner that's going to do that wellness visit, optimize your medical health before even getting to the pregnancy, because you want to make sure to increase the success rate of that actually working. So you want to make sure that your health is in the optimal situation versus just filling out money without actually having the workup done before the treatment.
No, that's a good one. And that leads right into what I was going to say before we get into some of the other conditions that people have asked about, some of the more popular, the endometriosis and the PCOS. Preconception care. Let's start there. What some of the best reproductive health in preparation to get pregnant. Let's talk about some of those things. So what's even considered a high risk age now? Because that's changed over time. It's dropped and gotten. I remember growing up, it was much higher than it was now. And when I first got pregnant, I think I was 34. And they were like, yeah, you're high risk. And I was like, oh, okay. I didn't realize. So let's talk about some of the preconception care, things like age. How does someone fare if they maybe have a history of miscarriages? Do all these things increase the ability or decrease your ability to conceive. Some of those things. If you want to start, Dr. Dean.
So
Preconception care. What do you suggest would be the first start when someone says, "I would like to become pregnant," if they're planning? Because as you
yeah.
mentioned, there's so many unplanned.
Yeah, so if someone is like desiring to get pregnant, one of the things that I would consider is like, do you have any medical issues? Do you regularly see a healthcare professional, get your annual exam done? Or do you have no medical issues that you see a practitioner for on a regular basis to manage those things? So for people who may not actually seek care unless it's necessary, they may have some underlying diagnosis that they don't know they have. So I would say, hey, you should have a wellness exam to kind of see, where are you right now? Do you have hypertension that you didn't know about? Do you have insulin resistance? You don't have diabetes yet, but you got pre-diabetes or something. So I would say starting off with that. And then also for people with no medical issues, there are some medical issues that we know it can get exacerbated through the pregnancy. Why does diabetes get exacerbated through the pregnancy? There is physiology that happens during the pregnancy that increase insulin resistance. That's why gestational diabetes is a thing. That's why controlling your diabetes actually gets a little bit harder in pregnancy, because the actual physiology of pregnancy makes things harder. But then there's some medical issues that someone may have where it has no impact on pregnancy whatsoever. Do you know which one you have? So starting off with that visit will help kind of know, or do you have a medical condition that makes you high risk, which means that it makes it a more complicated pregnancy for you. And it also means that it can cause complications for the baby. So we actually need to monitor the baby more during the pregnancy. And so having those conversations will allow us to figure those things out. And so then we can do those more closer monitoring for you than we need to for the typical patient who has like no medical issues, no high risk factors. And then you mentioned about like advanced maternal age. Well, the reason why we say advanced maternal age is 35 is because, one, we know that the ability to conceive, your fertility starts to decrease, but then you have increased rates of miscarriages at that time. And so then that's why it may be, and then also increased rate of genetic abnormalities. So you may have a higher risk of Down syndromes and things like that, which may recommend, genetic testing for a pregnancy if the patient desires. So then, because those things have a higher increased risk in patients who are 35 and above, that's why it may be possible to start that conversation earlier so that we can minimize some of those complications that happen. And while women may have a medical issue that needs to be addressed in their pregnancy, some people are considered high risk, but they are appropriate for me as a generalist to manage. Someone with diabetes, someone with hypertension, I can manage those things. But then some people have high risk conditions that I can't manage it. I need to have a specialist who is a maternal fetal medicine specialist that needs to monitor that pregnancy. And then the quicker that it has known conditions, then we can refer you to an MFM specialist if that is the situation that is necessary.
Oh, you touched on a lot, Dr. Dean. So first, when I got pregnant with my first, I was 37. So I think the term they were using then was geriatric pregnancy. So yes, so the first time you hear that term will just like rock you, like I'm 35, I'm 36, and I'm geriatric. So that makes you laugh a little bit, but it is what it is. And so I just took some notes as you were talking. So one of the first things that I would do, kind of like step 0 of the preconception journey, is to talk to your family members. In this country, and I think for women in general, we don't talk a whole lot about gynecological issues. We don't know who has had fibroids. We don't know who has had trouble getting pregnant or conceiving. We don't know if Aunt Joan is just living her best life without kids, or if it was, she had been trying and had suffered miscarriages in silence, right? So we don't know. So talk to the female members of both your family, your partner's family, if you're trying with a partner, just so that you understand what is prevalent in your family, because that's something that a reproductive endocrinologist is going to ask you. And so the other thing was Okay, so I knew diabetes ran in my family, but I had been active most of my life. And so when I was trying for my second and I hit the skids in my pregnancy, so from the very beginning, we knew that with insulin resistance, we'd gotten it under control, that I would be seeing, we just wanted to avoid moving into gestational diabetes at all costs. And so my OB was like, we'll get you working with an endocrinologist to make sure that your insulin resistance stays under control. So this meant that while I didn't have gestational diabetes, I was on a gestational diabetes diet. I was monitoring my blood sugar. So I was doing all the things. And I managed to keep from moving into gestational diabetes until the 36th week, when things really got chaotic with my pregnancy. And so at that point, it was, they were concerned about baby size and due to my age and everything. I was referred to a maternal fetal specialist, an MFM doctor, which meant that on top of my regular prenatal visits, I had to add in my endocrinologist visits. I also had to add in the maternal fetal specialist visits, where they go through, and those visits are not short visits. Those visits are long because they're waiting for the baby to do certain things. They're taking your blood pressure. And so I had a sleeping baby, so I had to eat. And so those were fairly long appointments. But I will tell you, as a Black person and a single parent going through the process, the bedside manner of some of them sent me crying to my OB. And I was just like, this is horrible. I can't do this. And so my medical team, because I had had a number of miscarriages in trying for my second, I was spent, and I was really vocal with my medical team in terms of, this is what I need from you. This is the care that I need. You need to understand my circumstances at home. I'm a single mom. I can't have a lot of surgeries. I can't have a lot of downtime. And so when I encountered some real challenges towards the end of my pregnancy, I told my doctors, y'all need to handle this, right? And it was just me just being blunt and getting the information out there. I'm anxious. This is an anxious pregnancy. I have a child already existing at home. And so my OB, when I went through the OB practice, I got to meet through my various appointments with all of the OBs in the practice. And I would say, look for a practice that does that, whether you're here or abroad. If you are managing parts of your pregnancy at home, see if you can get on a Zoom call and get to know the OBs in the practice, because you don't know who you're going to get. And so that helped me. And they actually came together and they supported me when I was uncertain about my pregnancy. And they said, look, you have a lot on your plate. Don't worry about this. We'll let you know when it's something to worry about. And that took a lot of the load off of me. And I think it was part of me having a dialogue. However it came out, and whatever Aisha's voice was, whether it was demanding, whether it was soft, I needed to make sure that they saw me and they understood that I need to come home with a baby and I need to come home alive. And so I did that during my pregnancy, but then I also did it when it was time to remove my fibroid. I used my reproductive endocrinologist to remove my fibroid because of an incident I had earlier in my adulthood when I got something removed. And the doctor asked me, do you want a cosmetic scar or just a regular scar? And I was like, you mean a jagged edge or a nice clean scar? And that stayed with me, because if you don't say anything, they're going to assume I'm just going to remove this fibroid, however I'm going to remove it, and not taking into account that you might want to have kids. Right? Not taking into account that you want to preserve your fertility. So you want to make sure that you are, if you can, and feel empowered to do so, to talk to your doctors every step of the way and make sure you get a doctor who listens to you. I just recently had to fire a doctor because I needed some care and they couldn't provide the level of service that I needed, and I had to fire them. And so don't be afraid to walk out of an exam because you're not being treated respectfully, because ultimately you have family members who want to see you come home. If you're trying to have a child, you want your fertility parts to be in working order so that you can go ahead and do that. And you don't want to get a sorry, I didn't know at the end after they've removed your uterus, right? So you want to be telling, and I have coached people, tell your doctor, whoever's removing your surgery, whoever's managing your endometrioma, that you want to have kids. So do whatever they can do to preserve your fertility.
Wow, that's really key. You basically said advocate for yourself. You have to advocate for yourself, and I think it's important. And I love that you said talk to your family members or your partner's family also to hear what they've seen, because you struck something in me, because I had not had that conversation. And I don't know if it's just you don't think about it, but when you get pregnant, I actually had a miscarriage first. And it wasn't until I had a miscarriage that my grandmother and aunt and another family member were like, oh, yeah, we all have a miscarriage first time. You'll be fine the second time around. I was like, oh, okay. Nobody told me. So, and there's a lot there. And then also for genetic aspects as well for your partner, depending on, how you're doing it. And then the advocacy piece that you mentioned in advanced maternal age, you're right. I had to go to several of those appointments. They were on top of the regular OB appointments. So there's a little bit more that people need to consider as you are advanced in your age. And then the advocacy, we can't say that more than enough. Research and advocate for yourself. And if you are, I know there's some people that have what they call white coat syndrome, where they kind of get forget everything that they want to talk about once they see a physician step into the room. And also culturally, there's some people who still believe in, oh, this person went to school and they have a number of years behind them. I'm not going to say anything. Whatever they tell me, I'll move on with. That's something that also comes into play as well when dealing with physicians and the whole advocacy piece. We can't stress enough how it's so important. It's vital that you as a woman, especially a Black woman, make sure that you are heard and advocate for yourself. And if you cannot do it, reach out to someone that loves you and can help you do that. I can't stress that enough. And I know time is of the essence. I did want to touch on two things because they were asked about endometriosis. And you only because you mentioned it earlier and it was something that came up. If you can just share what that is and briefly, and how people, if it affects pregnancy or conceiving at all. And then I just wanted to briefly touch on PCOS. And I know we have a little bit of time, but I wanted to touch on those two things before we go, if we can.
So when it comes to endometriosis, it is a disease process when we think about the uterine lining. The uterine lining is what you bleed off every month to have your menstrual cycle. So one of the theories is with endometriosis, you have retrograde bleeding. So usually if this is the uterus and this is the vagina, the blood is supposed to go through the vagina and out the body, and you're having a menstrual cycle. But you can get retrograde bleeding, which means that blood is going through the fallopian tube, and the fallopian tubes are open to the abdominal cavity, which means that some of those blood products can implant different parts of the body. So it can get on your bladder, it can get on the rectum, it can get on the diaphragm. And so what people will have is this cyclic pain that is related to the time of their menstrual cycle. It's also known to be like estrogen dependent, which is one of the hormones that happen in the first part of your cycle that is dominant. And so with that lining, people can have a lot of pain. People may have no symptoms whatsoever. The degree of disease does not match the degree of symptoms.
Okay.
And so it can also, you can get products that get to the ovary and cause a cyst and cause an endometrioma. And then also it can be an issue with infertility as well. And so with endometriosis, usually some of the times that will make me a little hyper aware that maybe somebody explaining this is, while it is normal to have a little bit of pain during your menstrual cycle, because that's literally the uterus contracting to expel the blood out. But when people have pain that's so severe that they're missing work, they're missing school, they're on a lot of pain medication, or they'll say, hey doc, I'm taking ibuprofen a couple days before my menstrual cycle start, and that helps. Those are things that I'm asking the patient, because that will clue me in that maybe this is endometriosis. Also, if it's only cyclic, it tends to be more severe 1 or 2 days before the menstrual cycle start. And then the first couple days of the menstrual cycle, it can be severe. And then it starts to taper down. So there's different questions that I'm asking, because there is this classic story of how it tends to sound. And those things I'm asking the patient if they're either volunteering that information, because they're like, oh, I'm having pain. But even if they don't tell me those things, I'm asking those questions about those different types of things that will make me like, oh, do I think this is endometriosis? When it comes to endometriosis, it is diagnosed by a pathology that requires a surgery, but not everyone wants an invasive surgery to get the diagnosis. So if your story sounds like it, and then I put you on a regimen that improves it without me having to do the surgery, then I'm like, this is what we think it is. But then some people will have more difficult cases where I do need to do a laparoscopic procedure, which means I drop a scope in the abdomen to take a look around, see if I see some of those implants, and then I take a biopsy, and then I can diagnose it definitively. But for a lot of patients, their stories would be enough to give me an indication that I think this is what it is. Try them on the therapy, and then if it improves, then I say, this is what I think it is. But technically, you need a tissue diagnosis to diagnose it, but not everyone wants or need the invasive surgery to do so.
Okay. Wow. Interesting. Okay. That's
Dr.
helpful.
Natasha,
Yeah.
before we switch gears. So this is I think an instance where medical bias can come into play, right? So because you're a woman, you have a menstrual cycle. Oh yeah, you're supposed to have cramps, right? Oh, you're 37 years old, you're trying to get pregnant, you're not getting pregnant. Oh, it's definitely the eggs, right? So I would encourage you to push back on some of that and go into, no, this does not feel okay. It doesn't feel normal, right? If it doesn't feel normal, if it's pain that a normal person would be like, this is pain, give more detail, because the medical establishment, a lot of the standards are from men in Europe in 1950, 1930. They did not take into account women. So while you're telling me my eggs are old, the sperm could be crippled, right? But men are the ones who are interpreting this, right? It's never the sperm. No, it's the woman's problem. So I would say start to push back. That was one of the things that I did not necessarily catch as I was going through my journey. And I had the white coat syndrome. I had the RE knows best, reproductive endocrinologist knew best. And I lost time on being able to use my own egg at some point, because I was listening to the doctors and we never looked at the sperm. And so if you are encountering these issues,
well, in most cases,
you're
supposed to look at both factors right off the bat. Like even though I'm not like, I will order the sperm analysis. I don't interpret it. If it's normal, we good. If anything is abnormal, I refer them. But I always tell people, like, this is a yin and yang situation. While the woman, there's two things I have to look at, because you are the house and you have your ovulation stuff I have to look at. But there's always a him component in this situation. And I argue that any practitioner you see that don't look at both people contributing to this situation and do both workups for it, then you need to find somebody else.
Thank you. Thank you. I appreciate that one for sure, because I do know someone who was ran through a battery of tests, and they were telling her simply because of her age, oh, this is because of that and other things going on with your eggs. And it turned out it was the husband who had a very low sperm count, and it wasn't even the physician that ultimately led to the decision to have him tested. It was a family member. I was like, why don't you have him tested just to see? You've been through everything. You eat healthy. You've done this. Everything's come back normal. Go ahead and have him tested. He went to his doctor, got tested, and sure enough, it was him. Right. So that was really helpful, really, really helpful. And while we have I hope you have time for one more, Dr. Dean, just
Yeah.
PCOS, if you can touch on polycystic ovarian syndrome, because that seems to be a big thing with Black women as well. And I know I've gotten some questions about that as well, just what it is and how that may affect a pregnancy as well.
All right. So for PCOS, this is a big endocrinology situation. I, as a gynecologist, manage it, but there's a hormone imbalance. So, how I kind of describe this to my patient, someone who is genetically female, they have female hormones and they have male hormones called androgens, but their female hormones is higher than their male hormones. For people who are genetically male, they have both sets of hormone. It's just their androgens are higher than their estrogens and progesterones. When someone has polycystic ovarian syndrome or PCOS, those androgens are increasing. What can cause increased androgen? One is obesity. So there is an enzyme that converts the female hormones to male hormones. But in adipose tissue, which is fat cells, that enzyme increases more of those estrogens to make androgens. And when androgens starts to increase, it impacts the menstrual cycle and then therefore causes issues with ovulation. Mm-hmm. So someone who has PCOS, they're not ovulating regularly. When someone says, I have a menstrual cycle every month, the reason why they have a menstrual cycle every month, if they're not on any contraception, is because they are ovulating every month and then they're having a predictable bleed every month. But someone who has PCOS who is not ovulating every month, they having irregular menstrual cycles. They can't tell me when their next menstrual cycle is going to be. Also, another sign that I usually kind of tell my younger patients don't like to use contraception, but they're not getting pregnant. I'm like, that's not normal. If you're not on contraception and you're not having any accidental pregnancies, you have some issue going on. And so even for patients who are not even PCOS can cause infertility, but even patients who's not thinking about infertility because they actually don't want to get pregnant, but they're not doing anything to prevent it. I think about like, hey, you could have PCOS. We probably should work this up, which is why one of the things that is regularly asked during a gynecological visit is, when was your last menstrual cycle and do you have regular menses? Because if you tell me you don't have regular menses, I'm already got an alert. Could you have undiagnosed PCOS or some anovulatory situation that may not matter to you now because you're not thinking about pregnancy, but will be important to you if that's something that you desire. And with polycystic ovarian syndrome, not only can it cause issues with infertility because they're not regularly ovulating, they also have an increased risk of diabetes because it also relates to insulin resistance. They also have an issue with hypertension. They also have an increased risk of endometrial cancer because they have a higher level of estrogen in their body and not a lot of progesterone. And so this is what we call unopposed estrogen, since they don't ovulate regularly. And that unopposed estrogen leads to increased risk of endometrial cancer if we're not doing something to address that. So when it comes to PCOS, it is a syndrome, which means that there's multiple things throughout the person's lifespan that we need to consider that they are at an increased risk for, that we need to minimize that. So for instance, I mentioned they have an increased risk of diabetes. They may need to be screened for diabetes more frequently. Because they have an increased risk of endometrial cancer, they may say like, hey, doc, I'm not interested in getting pregnant. I want to be on the contraceptive. I may recommend a certain type of contraceptive that also will help with that increase of endometrial cancer later on in life. They may also have this issue with hypertension. So then, are we monitoring their blood pressures and things like that? So while there is the infertility aspect, there's a whole slew of medical issues that patients with this diagnosis are at increased risk for. But then the other thing that I kind of tell people, while polycystic ovarian syndrome or PCOS, there is a relation to obesity because of that pathophysiology I mentioned earlier. A lot of this stuff can be reversed with reduction in weight by 5 to 10%. So then just by reducing their weight, their menstrual cycles start to become more regular and more predictable, which means that they're ovulating, which means they may actually have a natural conception without me having to give them an ovulation inducing medication to kind of help with that. So so just that's kind of tips of the iceberg of what PCOS is.
Right.
And then
Oh, go ahead. Go ahead.
I just wanted to add, so I know in the States, there are some fertility clinics that have a BMI cutoff. And so if you are considering IVF or intervention here in the States or abroad, one of the things to look for is if you can find on their website, or if you talk to a doctor during a consultation, to ask them do they have a BMI cutoff, or what's their approach, because that is a thing. So to be aware
Good to know. That is good to know. With you saying that, with the weight loss, I knew that it was helpful for them to lose weight for PCOS. The problem I found is that everyone that I know that personally has it, it seems as if there is a barrier to them losing weight, despite trying a number of different methods, increasing their exercise, eating healthier. It seems like just having it creates an issue for them, almost like with the menopause and how you put on weight as you get older. So is there something related to how much more difficult it can be because it's hormonal with them losing weight?
It's a metabolic situation. So again, just like, me at, what am I, 37? My metabolism not the same as was at 25. So I have to be more intentional in how I eat and how I exercise. Not the fact that I do it, but how I do it in order to see the results, when I could just like think about it a decade ago and it will work. So because it's a metabolic situation, a hormonal situation, sometimes it takes different approaches to the nutrition. And so sometimes it's working with a professional that can tailor things specifically to you and your body type is something that is necessary, when previously, when you wanted to lose the weight or whatever, you could do it on your own. So that's one of the ways that can kind of help with that, because that hormonal imbalance can make it harder. Just like in the menopausal phase, that change in the hormonal balance makes it harder to lose the weight. So then you can't use the more generic approach. You have to do it that's like more tailored to you.
Got it. Okay, good.
And I will say that was one of the indications that something was not right with my blood sugar, was that I was working out, the weight was not coming off, I was exhausted. And that was one of the things that, kind of was just like, something's not right here. And so whenever it's just like, I'm so exhausted, I can't, take the weight off. It may not 100% be you. It could just be the metabolic systems in your body that's not functioning up to peak performance. So.
Absolutely. Absolutely. So I know that we are at time, and I thank you both for participating in this. This was an extremely helpful conversation, and I hope you guys watching found it to be as well. I do want to ask you one thing. If we were to take away one thing from this conversation, both Dr. Dean and Aisha, what would you like our Black women to know when it comes to just general reproductive health, something to take away for them? And either of you can answer that first.
I would say start early. It's a conversation with your doctor at any point in your mid-20s, and you're thinking that kids might be in your future. Just ask your doctor, your gynecologist, your OBGYN to run a fertility panel. Knowledge is power.
Yeah, absolutely. Thank you. And Dr. Dean?
So I'm all about just like preventative health, because even if you're not ready to seek pregnancy at this time, if you're doing your wellness exams and different things like that, your practitioner can pick up things and help you with that information and how this may apply when you are ready for that. So for instance, if I see a patient that may be obese, who has irregular menses, she's only 22. So she's actually happy that she's not having menses every month. But then just seeing her for a wellness exam is like, hey, I know you don't care about this today, but if you desire to have kids, I'm concerned you may have a medical condition that may make it a challenging. So let's see if we can diagnose this thing and then help you figure out when you are ready for that, what are the options that are available to you. versus
Makes
just only having to learn about it once you're ready. And then now you learn you got all these different medical issues that you need to optimize. But sometimes we can catch some of these things early, but then that means you have to come to your annual woman exam.
Makes sense. And I thank you both. And what I would say for you all is advocacy. In addition to starting early and having those conversations, advocate for yourself. The whole purpose of this channel is to make sure you are armed with as much information as possible to ask questions. It's about your health. Nobody knows your body better than you. So we want you to go in there armed with enough information to make the most informed decisions, to have the best outcomes, whether it's for pregnancy, just for reproductive health on a whole, no matter where you are on the spectrum in terms of age and in your journey. So with that, I want to thank you both for participating. And I want to, I know Dr. Dean is extremely busy and cannot, she's not going to give out her contact information, but if you all have additional questions, I'll be willing to collect those and I'll collect them up to the end of the month and submit them to her. She's willing to answer them as she has time, and then I can come back on and share that or get back to you. But for Aisha, if you don't mind sharing information on your podcast and your organization before they go, and I'll drop in the links, your website for Start to Finish Motherhood.
Yeah, I'd say check out the podcast, check out the YouTube channel. I partner with women looking to get started on their single mother by choice journey. I have friends who will refer their friends who are partnered just to kind of pick my brain from the 3-year journey that I had to my second child. I tried everything and I finally got her, but it was a college level course in fertility and infertility and advocating for myself. So check out the podcast if you're interested, but definitely the YouTube channel. And Dr. Natasha put my website in the chat, and it's been great. Thanks for having me.
Thank you both. I appreciate it. And everyone, be well until next time. Thank you.